Okay, hello everyone. Welcome. Welcome to the Gender Equity Unit's new webinar series, Gender, Data, and Equity Expert Conversations. For those of you who are not familiar with us, the Gender Equity Unit is part of the Data for Health initiative and is funded by Bloomberg Philanthropies. We're located in the Johns Hopkins Bloomberg School of Public Health. The aims of the unit are to serve as a knowledge center and resource hub for all partners and countries in the Data for Health initiative and beyond, to integrate gender equity into their work, to provide capacity strengthening activities focused on gender equity for partner liaisons and key country players. And we also conduct research studies to demonstrate the importance of barriers to and strategies for advancing gender equity in global public health data systems. We're very honored to have so many joining us for the next hour from around the world. So again, welcome. A few notes at the top. We will have a Q&A session at the end of the webinar. But please feel free to write your questions in the chat throughout our conversation, and we will save them for the end. You're also welcome to raise your hand and come off mute during the Q&A section to ask a question. We will also be sharing a very brief survey in the chat that helps us to know who our audience is, where you're coming from. So if you could take a minute to fill that out, we would appreciate it. Today, I am hosting a conversation with Dr. Will Cole. Will, so great to see you. Dr. Will Cole is a public health research consultant specializing in gender and health and transgender health more specifically. Will earned their MPH and MA from Yale University and then a PhD in international health and post-doctoral fellowships in epidemiology and in health behavior and society at the Johns Hopkins Bloomberg School of Public Health. Will has been faculty in the Department of Health, Behavior, and Society since 2015, and that's how we got to know each other a bit. Will spent over a decade living in Tanzania, working on empowerment and HIV prevention for vulnerable women. In 2018, he realized he is transgender and moved back to Baltimore so he could transition and become an advocate for LGBTQ rights and wellness. This has included teaching courses on domestic and global LGBTQ health at Johns Hopkins. Now, Will is the owner and principal consultant at Query Research Consulting. His clients have included Harvard's Boston Children's Hospital and Brigham and Women's Hospital, the World Health Organization, the National Academy of Science, Engineering, and Medicine, and the National Center for Transgender Equality. Outside of work, he is pursuing an MA in writing creative nonfiction at Johns Hopkins and is also a husband and a dad. So clearly you keep busy. Please please join me in welcoming Will. So great to have you.
Thank you, Michelle. It's good to be here and good to see you and good to see all this audience.
All right, so I'm going to get started with some questions, and I'm looking forward to hearing your perspective on a variety of things. So first of all, one thing that I think about a lot is how can data systems more inclusively capture the variety of identities on the gender spectrum? What thoughts do you have on this question?
Yeah, it's a great question and one I've been grappling with a lot over the past few years, and actually have a paper coming out in American Journal of Epidemiology about this with several colleagues. So I refreshed my memory this morning about what we wrote, but basically we want to include trans people, right, and non-binary people and others in all of our regular data systems, in our surveys, in our national surveys, and like trans people are already there. They're in the survey. They're just misclassified, right? We are a part of every population. So any survey you're doing, you're likely to have some of us in there. We're just misclassified. So there aren't like gold standard or best standard approaches, but there are better standards. And these are all under conversation right now, given how we're still developing terminology and words, and these are rapidly changing as things are going. So staying up with the terminology and standards can be challenging, but totally worth it. So basically, you want to separate sex and gender, right? And a health equity unit knows all about this. We know gender we use to refer to the social aspects, sex to refer to the biological aspects. And that's really helpful to then take it a step further and see sex and gender both as multidimensional constructs. And so depending on what you want to capture and what your research question is, you're going to want to get into more depth about gender or sex or both. But at the very basic level, you want at least a two-step approach. There are multi-step approaches too, but at least a two-step approach where you ask gender identity, current gender identity, and sex. And that can be sex assigned at birth. If you really need to look at biological aspects of something, you're going to want sex assigned at birth because that's going to matter to your, biological medical outcomes. If you don't need the biological outcomes, you can just ask current gender and include, but having legal sex or sex assigned at birth will help you identify, in particular, trans people who don't identify as trans. So there's, I identify very strongly as a trans man, and really want that adjective trans in there. But a lot of people see their transgenderness being sort of a verb that happened at a certain time while they were actively transitioning. And now that they've achieved their transition goals, they're just a woman or just a man. So on a survey, they're going to answer male or female or man or woman, depending on how you ask it. And so having that two-step approach allows for you to capture them as a man who was assigned female at birth, or as a woman who was assigned male at birth, or a non-binary person that was assigned either. And that way you can, cross-examine those two questions and figure out who is of trans experience, even if they don't identify as such. So that's the baseline I encourage people to use is a two-step approach that asks gender identity and sex.
And so what happens if that two-step approach is not used? How are trans people then, where are they typically classified?
That can go multiple ways. One, it could be that people see that and sex, male, female are the only options, or men, women are the only options, and just completely opt out of answering or not engaging. I've done that before. I wanted to engage in COVID vaccine research at Hopkins when it was early pandemic, and I saw they only asked male or female, and I said, this isn't enough for me. And I emailed them and said, hey, these are reasons why you should be more inclusive, but this isn't, I can see that there is no place for me here, so I'm not going to engage. Mm-hmm. That happens a lot. You're just not capturing people because they don't feel welcome or seen. But if they do participate, then they're misclassified, and then you have misclassification bias. If I have to participate in something and male and female are the only options, or man or woman are the only options, I'm going to pick male or man, absolutely. But for things that are medical or biological, that also gives me pause, even like going to get a vaccine, you're filling out the forms and it'll say, if for women, could you be pregnant? Or, and I always cross that out and say, if relevant, or like you really don't need that. You can just say, if pregnant, like, are you pregnant or not? People who don't have a uterus will absolutely say no, so when they do participate in surveys, when they do give their information, often they're in such small numbers that the analysts don't know what to do with it.
Yeah.
Even if they aren't classified correctly. And so they end up just sort of kicking them out of the analysis, and then we're rendered invisible. We're erased, even though we're there. We're, literally erased from the data, um, which is troublesome. And there are absolutely cases where you're going to have a very small trans or non-binary sample size, maybe too small to analyze with the cisgender people. Um, and in that case, I encourage you to give a narrative of why that is.
Mm.
Maybe they're not in the table, or they're not in the regression, but they're in the, table one characteristics of, of the sample. But then give a narrative of like, hey, we tried, we only got this N. Here's why we think we didn't do better recruiting trans and non-binary people. Um, Here are some basics about them, and that sample, but we just couldn't include them in quantitative analysis. Sort of make it a narrative, qualitative sort of piece, um, as long as it doesn't also identify any of the people who were involved or compromise confidentiality, privacy, because in really small communities it could. But yeah, that's what I encourage is giving that narrative of, hey, we tried, it wasn't good enough. Here's what we know.
Yeah. Yeah, that's great. And then I was going to ask that follow-up question of, because I've heard researchers say, well, it's such a small cell size for these individuals, like you can't do anything with the data. But what I hear you saying is that, well, you should be reporting what you have, even if it's not something you can do, further analyses with.
Exactly. I've had to do that myself,
Mhm.
where I had trans and cisgender female sex workers looking at their drug use patterns, but the size of the sex workers who were trans and drug users was so small that I couldn't include them in a latent class analysis with the cisgender women. Also, because the variances were so different, the drug use patterns were so different, I ended up having to exclude them from the latent class analysis, but I did write that in the methods. Hey, I tried. There are these women, their patterns are different and they look like such and such, so they were at least acknowledged. I tried so hard to include them. um, and it just didn't work analytically, but I made sure to include that.
Yeah. Well, so my next question is, in your research and the work that you do, what do you think are the main health issues that are facing transgender people in the US?
In the US, there are a lot of health issues, and it all boils down to stigma and discrimination. Like it all comes back to that, Michelle, you're familiar, of course, with the um, minority stress theory, where physical and mental health outcomes ultimately come back to stigma and discrimination from society. And I, of course, teach that to my students and will preach it to anyone will listen that there is nothing inherent about being transgender that causes poor health outcomes. There's nothing wrong with being trans or non-binary that impacts our health. It is societal discrimination and stigma and that chronic stress, the even complex PTSD that results um, from that stigma, that discrimination at all levels of society. So, individual, familial, community, institutional, with policies, access to healthcare. At the interpersonal level, you have family rejection. Um, there's a lot going on at all levels, and that's what then leads to we absolutely have disparities in mental health, worse anxiety, worse depression, worse psychological distress, higher rates of suicidality and completed suicide. Um, and and then on top of that, a lot of other health issues that could be um, attributed to maladaptive coping strategies because of all this stress. So substance use, alcohol use, risky sexual behavior, self-harm, including suicidality. Um, and what what we know most about is mental health substance use, and HIV and STIs. So those are the, the hot, topics, and suicidality, especially among youth, related to mental health. But that's mostly just also because that's what we've looked at. There's very little data on chronic health issues. And one of the reports I wrote recently was about all these other comorbidities and chronic health issues, and like, what do we know and what don't we know about, heart disease and cancer and all these other things, osteoporosis, bone health, and we just are lacking so much data. And but where we are looking, we're seeing there are disparities in some places and there aren't in others. Like there's a lot of worry about cancer from hormone use, and there's actually no evidence that it increases cancer at all from what we have, But yeah, mental health, especially right now, is a really, really big, important issue we need to be thinking about. There's so much going on in the world and in the US that's really impacting trans and non-binary people's mental health.
Yeah. Yeah. So I'll ask my colleagues to share a link to the Global LGBT Health book that recently came out that you contributed to. And that was a theme throughout it, that we often don't have enough data on, like, we know in smaller surveys that these health disparities exist, but getting sufficient data on all of the health impacts of minority stress, and the stigma and discrimination that particularly transgender people experience. We need to do better in capturing that data. Yeah. So the last thing you said, in the US, transgender people have been a real target from some politicians in recent years. Can you speak to the impact of this targeted harassment and often violence towards transgender people?
Yeah, that is really, really huge. And sort of where we are in the United States right now with this patchwork of trans rights and trans discrimination across the states really calls back to 10 and 15 years ago, when we had the same fight about same-sex marriage and marriage equality, before the federal, change. And we've gained a lot of visibility in the past few years, and now this is a backlash coming against that visibility. But also it's a very political, targeted effort where politicians realize trans issues could be a hot button issue to get votes, and so they have used trans people, especially trans youth, as political pawns in their fight to get votes. And you know, even a couple of years ago, I was saying they're throwing trans youth under the bus. They're using them as pawns, and there will be death and violence as a result, both suicide and violent death. And we saw this last week when the news really hit about Nex Benedict, who was beaten by schoolmates in their bathroom, in the one that their state required them to use, that made them unsafe. And we've lost a beautiful 16-year-old non-binary soul. And the trans world, especially in the US, is just in this collective mourning of seeing the outcomes of politicians and people who really have no stake in it. Why do they care about people like me? They are debating us, debating our right to exist, debating our right to legal recognition, debating our right to use bathrooms. And people are literally dying because of it. Not just Nex, but by suicide, by if you know any trans youth, non-binary youth, they are not okay. Please reach out to them. Please tell them you value them. I have trans youth in my life that I checked in with this past week, and it's incredibly frustrating and is also not surprising that this is the outcome. We knew this would happen. And I think the politicians who are pushing against our rights knew it would happen too, and they don't care. That's certainly what it feels like, is that they want us eradicated. They want us to not exist. They want to push us back into hiding like we were before. Because we've always been here. There's more trans visibility, but trans people have always been here. Non-binary people have always been here. We just haven't used those words to describe us.
Mhm.
And we haven't had the words to describe ourselves in order to be able to say, oh, that's me, until much more recently. I didn't have the words to describe myself when I was a kid or even a teenager. And it took me almost 4 decades to find the words that fit for me. And I'm glad I have been able to figure that out and transition and have, be lucky enough to have had a supportive work environment and health insurance and, all the things falling in place for me that it worked. But so many people are not in such a position of privilege and are literally fighting for their lives on the streets. And, it is really dehumanizing, be forced into second-class citizenship. My own home state of Utah used to be one of the surprisingly progressive states when it came to trans issues, considering they're a very Republican conservative religious state. They were actually pretty good about it until recently, and now they've gone backwards, taken healthcare away from youth, and most recently have a bathroom ban where it is illegal for me to use the men's room, and they want me to use the women's room. By the law, I should use the women's room. And I guarantee no one wants me in the women's room. And I've just told my family who still live there, I'm not visiting as long as this bathroom ban is in place. I am made illegal in my home state, and I won't tolerate that. And I certainly won't go to Florida, and I certainly there's other states I just won't go to because it's not safe. And that's heartbreaking and ridiculous.
Yeah, and a great psychological toll to have to think about those things, right?
Yeah.
And to go back to, the first topic we were discussing about data, I work with some people who have dashboards looking at public data by cities, by state, and things such as homicide data is often not reported at the state or even smaller jurisdiction levels by gender identity. Right, it's
Yeah.
often by biological sex. And so you often miss the true rates of homicide or violent crime against people who are transgender, when you don't have both the sex and the gender identity noted in death records.
Exactly. And we know, like, we've been tracking for many years and honoring people on Trans Day of Remembrance, November 20th. And, we speak the names of people who have been killed in the past year. And it's a rising number, but it's generally in the 30s in the United States. And it's almost all Black and Latina trans women, not entirely, but, next will be on the list this year. And yeah, that's just the ones we know about. There's so many who get misgendered in their death. And it's one of the great fears of all trans people. Like, I want to be buried as a man. Hopefully that happens, but there's no guarantee because of this issue. Like you said, in mortality, we are not recorded accurately.
Mhm. So how can people, cisgender people, do better to support transgender individuals, especially during these times where there has been a rise in harassment and violence against transgender communities?
Yeah. Definitely educate yourselves. And also don't put that burden on your trans friend of being like, hey, teach me all this stuff. A lot of people like myself are willing to educate and have these talks. So seek out such people, seek out, resources that already exist. And if you need to ask, if you don't know where to look, ask a trans friend, hey, I really want to learn more. Where should I go to learn? And I bet they'll be happy to tell you some places. There's lots of online resources. There's lots of books. There's lots of trainings. So, if you can attend those trainings, attend those webinars like this one, where someone's talking about it. And there's stuff that's already recorded, of course, that you can seek out as well. And another thing is to amplify trans voices. Follow influencers, buy their books, subscribe to news, follow sites like Movement Advancement Project that maps all sorts of policies, the Human Rights Campaign, the Trevor Project, and then also like individuals. There's a lot of individual influencers, TikTok, Instagram these days, and follow them and repost their content, and um, and also speak up, especially when your trans friends aren't there. Speak up, correct people if they misgender someone, um, and push for inclusive policies at work, at school. If you have kids, you're involved with the PTA. You don't have to wait until you have a trans kid in order to make things inclusive, right? We want schools and workplaces to be inclusive. And like when I was already in the department with you, Michelle, when I came out, and I was the first trans person, at least who was out in the School of Public Health in Johns Hopkins history. And so, I was willing to step up and say, hey, we need this, we need that, and, gave a training to the department at our retreat pre-COVID. But also other faculty members stepped in and said, hey, we need to have policies about names and, signatures with pronouns in them, or, fix name change policies so people can change their name on their ID before they have their legal change, which was a big issue for me before I was able to change mine. So that all that burden doesn't fall on your trans coworker or friend. And there are, again, resources online, toolkits of what to do in school, toolkits of inclusion at work for DEI people, for HR people. A colleague just published a book about trans inclusion in workplaces. It was all the questions you want to ask about your trans colleague, but shouldn't. So, get that book, AJ or AC folks, and, educate yourself. And then lastly, I think really speak up politically. Call your lawmakers, write your lawmakers, speak up at town councils, tell them that you're supportive. So it's not just this small number of trans voices speaking up, but everyone saying, yes, this is what we want. We want inclusion. We want them here. We need policies that will support them.
Yeah. I remember when you were really speaking up about making things more inclusive in the School of Public Health. And I know that there are a lot of students and faculty who are very grateful that you used your voice initially to do that. So I'll say thank you on their behalf.
Yeah, it's really beautiful to see trans students in the classes now.
Yeah.
Yeah.
I want to shift gears a little bit and ask how must we think differently about these issues in other parts of the world, particularly low and middle income countries? I know there's gender diversity in many cultures around the globe, but oftentimes it's very dangerous given political environments to raise awareness of these issues. So from your view, how do we address these things in other countries?
Mm-hmm. So I want to sort of separate it into two. One is that political safety issue, which I'll come to second, but first, cultural diversity. And as you said, gender diversity exists. It exists throughout the world, throughout time. We have lots of historical, archival, and current, anthropological records that show lots of cultures have third, fourth, fifth genders. They've recognized and accepted gender diversity, or at least had it, even if it was stigmatized, all over. So it's not this new white Western, thing that we're trying to export onto other people, right? That said, we do need to be very careful about not exporting our Western labels and our Western views onto other cultures. I think this is a, a problem in global health generally, and we need to be more careful about it. And one way to do this with gender diversity and trans folks is recognize that there may already be words for similar things in local languages and local identities that are similar but do not map exactly onto words we use. For example, Hijra in India, it's very easy to say, oh, that's a trans woman. But a lot of Hijra themselves don't say, no, I'm not a trans woman, I'm something else. It's this other third thing. And that's valid. It's not that our way is right or true, or it's just what we're using right now. Our definitions are bound in time and place just as much as any, and our words aren't the right words or the right categories, right? So you really want to be working with local culture and local stakeholders of trans and non-binary people, LGBTQ groups, whatever words they use for that, to make sure you're appropriate in a culturally sensitive way and accurately capturing what is going on locally. And some of those categories may be fuzzy, like in LGBTQ health these days, we very strictly sort of separate sexual orientation and gender identity. It's very useful to talk about it that way. But in a lot of places, including 50 years ago here, those were very intertwined and not separated, not conceptually separated. And so you do need to respect that sort of thing as well. And just, if you're going to go work in a different country, in a different subculture, even including in the United States, if that's with Two-Spirit people or Native Americans, you've got to partner with local groups. And a lot of countries, surprising number of countries with very stigmatized, that stigmatize trans people very greatly, do have trans organizations. They may be small, they may be underground, but they exist. They exist in Uganda and in Kenya and in China, and they exist everywhere. So that's where you would start. And it's also very important to respect their needs and wishes. I was working last year trying to get some programming into some research into Kenya and on LGBTQ issues. And the local group there said, no, it's too dangerous. You will get us in trouble. You will expose us, and the harm will come to us, not you, the foreigners, right? So they said, no, don't do it here. We're not willing, we're not ready. And it's really important to respect that kind of thing, because it is true, it could get locals more in trouble. I've seen it happen before with MSM, Men Who Have Sex with Men programming. It got locals into trouble, and the white people get to just fly back out, right? So it's very important to truly partner and truly respect what the local people say they need.
Mm-hmm. So how do you approach the cross-section of research and advocacy? Why don't we start with when you're working in settings outside of the US and then go to US context?
Outside the US, oh, that's like, I have to tread so carefully.
Yeah.
Because again, the worst that could happen to me is I get deported.
Yeah.
And that's not true of people who lived there. I have the privilege of being able to leave. And when I was in Tanzania, when I figured out I'm trans and first started coming out to, very select people, and did think about, do I stay and work with LGBTQ groups here? Do I try to use my voice here, my expertise, my privilege? And decided I couldn't. And I know other people will make different decisions, and that's valid. But for me, and how the government was at the time, I felt like I would just get too many people in trouble, including myself, and would get deported. And um, I considered it. Like, I'm like, I would wear that as a badge of honor, honestly. And I have a friend, American friend, who was deported for advocating for gay rights. But I decided that's not what I want to do. I didn't want to get any of my colleagues in trouble, because whether or not they were involved, and they weren't, they would be questioned. So I decided I wanted to come back here, where I am an American citizen, where I know the government, I know the playing field, I know the rules, and I would be able to have more of an impact, and also still can do and also do global work.
Yeah. All right. We will go to Q&A. So please do enter your questions in the chat. And while our audience is thinking about questions, I did want to ask you, the work you're doing, both from an advocacy standpoint and on research, and being, part of the community that is involved in this research, how do you manage all of that for yourself, emotionally? How do you take care of yourself? Because as we've been saying, there are so many health disparities for transgender people. There are so many points of examples of harassment and violence. Like, how do you manage to do that sort of work and not sort of fold in onto yourself at the same time?
Yeah, that's an ongoing an ongoing work. I mean, I cried last week when I learned about NEX. I cried all through a therapy session. I felt hopeless and just so grief-stricken, not just about NEX, but about how the whole country is going, and how many more youth are suffering that we're not seeing in addition to NEX. And it is really hard sometimes. So I have tried really hard to make sure I am taking care of myself, my body, letting myself have that grief, instead of trying to just tamp it down. I definitely go to therapy. I, do things like meditate and exercise and hide under my weighted blanket as needed, so that my body is prepared for, when I have to step up. And I do step up. I all of my clients are it's transgender health research. I teach, of course, this global LGBTQ class, and I volunteer. Also, I'm on the board of Maryland Safe Haven. It was Baltimore Safe Haven until recently. That works, locally to support LGBTQ, especially Black trans folks in Maryland. And I also, I speak about the disparities, of course, and I also try to balance that with some acknowledgement and attention to trans joy and euphoria. If any of you saw my screensaver for Zoom, it's a word cloud about that a friend of mine made for a presentation that we've given in a couple different contexts, including just in class last week. We were talking about assets and strength-based approaches, community, social support, these things in LGBTQ health. And so I talked about trans joy and euphoria and all the goodness and joy and happiness that comes with transition, and reframing gender affirming care and gender transition from a thing with risks and scariness and medicalized into a thing that's a beautiful sacred process of becoming. And therapists and doctors have the privilege of being able to work with people who are transitioning. And I asked the class, what do you associate with trans joy? What words do you have for trans joy? And they were just blank. And I thought, have you ever thought about it? I asked them, and they all said no. I've never thought about it. And I, I've taught this class plus a different LGBTQ health class, and those disparities really do weigh heavily on my soul since I've been involved in this class since 2018, 2017, in fact. And so I've introduced to the class what I call queeros or queer heroes. I got this name from a podcast from Cameron Esposito. So I end every class with students presenting queeros, which are, a people, place, or thing that's helped you, or LGBTQ people feel safe in who they are, or show them that they can be who they are. And so in the context of class, that's, internationally influential people. The one from last week was a Dene or Navajo Nation person that started Dene Pride. His last name is Nelson. And the week before that was someone from Japan, a trans man from Japan, and sort of all over the world, we're finding people who are doing good things for LGBTQ people. And I never want to veer into territory of toxic positivity, but we need some balance to take this bad taste out of our mouths at the end of every class so that we feel a little glimmer of hope, of joy, of activism. And that's been really important to the classes I've taught, and I think the students really appreciate that as well.
Yeah, I love that. So I taught that course before you came on, and I remember it just being very heavy in the content. So I'm glad that you found a way to end sessions on a positive note. And we often think in public health about health disparities, right? We're focused on those negatives, and you can almost think about the transitioning period and adopting the identity that you're felt you were meant to have as a health promotion process, right? So making it more of a positive outcome. I do have a couple of questions from the audience. So Anne said, I really appreciate your point about listening to colleagues in country when they say it's not safe to collect data or advocate. Do you have suggestions for how to handle it when it is US-based researchers who refuse to consider collecting these data without discussing with local partners because they just assume that it won't be accepted?
I assume it won't be accepted by whom, I guess is my question. But
I
yeah,
can speak up off mic if that's clearer.
Yeah,
Sorry, I was thinking about a situation where I suggested having a more gender diverse questionnaire, and we were just told like that won't be accepted by communities where we're collecting these data, but it was coming from US researchers and not from the local partners. And there was no discussion with local partners about, is this actually something that would be accepted, or is there a way to phrase this better?
Yeah, I get that a lot. I see that a lot. Hopefully my paper coming out will be something you can just hand them and be like, here's all the reasons why you should do this. But yeah, I hear people saying like, oh, they'll be uncomfortable, or like cisgender people won't understand it or make them uncomfortable. But these have been tested and validated, and they work. Cisgender people understand them. They're fine with it. Also, we ask a lot of private things all the time. We ask about sexual behavior. We ask about income. We ask about, marital fights. Like, we ask about a lot of sensitive stuff all the time, and no one's shying away from that. We're just making sure we do it in sensitive ways. And this is similar. And I have had people say, including people in high up places in federal government, say, well, that makes sense to do for an LGBTQ project, but not for a general population project. And I'm like, no, 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 no. We're everywhere. We're everywhere. You're just not asking us. So yeah, please continue to push back. And yeah, for health equity, for acknowledging us as humans, for reducing bias in your sample. There's a lot of reasons that you could appeal to, hopefully that will convince people.
Thank you. All right, a question from Martha. What advice would you give us LGBTQI plus folks advocating for trans visibility in data collection, recognizing that LGBTQI plus cultural competence remains an issue?
Yeah. Thanks, Martha. One example that comes to mind with that is like you want to promote people going to healthcare, but not if the healthcare is going to be terrible to them. Like if there aren't doctors that know how to handle trans people, why would you encourage trans people to go to them? I think we have to work on all the things, work in parallel, and we all have our lanes, right? Like, so if you're in research, you can do your part on data collection, and other people working in DEI or cultural competency or continuing medical education credits, encouraging classes on how to treat us better. Yeah, and speaking up about cultural competency wherever you can, and even including, I was talking about other countries with working with local partners and having different language and different names, but that is true within the United States too, with subpopulations, racial groups. African Americans use different words for LGBTQ stuff often, but not always. Of course, Native Americans use different words. And so it applies everywhere where you need to be culturally competent on all the things, on disability, on race, on neurodiversity. We have, it's a lot of big steps up, but I believe we can do it.
All right. From Sarah, are there best practices for research that include a diversity of gender identity options that also involves voluntary biomarker data collection, which are based on a sex binary? So she gives the example of hemoglobin cutoffs for anemia.
Yeah, that is actually a big issue in a lot of different health fields, from pulmonary function tests to osteoporosis to size of tubes for intubation. There's a lot of things that's sex-based. Unfortunately, those things are often sex-based as a proxy for something else, like muscle mass or height or weight or things that are actually totally inappropriate. Like that trans people are like, they don't fit, right? Like I recently had pulmonary function tests and I had to ask the doctor who knew I'm trans, are you looking at male standards or female standards? Or something in between. And in one of the reports I was doing recently, I did have to look at what standards exist for a lot of these things. And we're in the place of case studies right now. That's all we've got. We've got a case study of a trans man who was intubated with the wrong tube and it screwed up his throat. We have, all these different tests that we need nuance in. And there are some now that involve sex in the calculation of are you over or under. And there was another case of someone who had kidney failure and was classified wrong because of sex versus gender and ended up needing a kidney transplant eventually that he shouldn't have had to have, right? So there's standards now that some of them are like taking sex out of the equation. Yeah, BMI is another. So like even myself, I'm like, which BMI do I go by? I don't know. Is it somewhere in between? BMI is trash, but we still use it anyway. And yeah, hemoglobin, I was always anemic before, I'm not now. Like, we need to really examine those and examine which dimension of sex we actually mean for them. Sometimes it's hormones, sometimes it's chromosomes, sometimes it's just weight and height averages, sometimes it's, other things. And we really need to get down to the nitty gritty, especially on things where like there are things where it really matters, like the examples I gave, but also like with disordered eating. Disordered eating is very sex-based, and that has caused problems for everybody, including cis people. So yeah, all of those need to be examined. Sex is at least 5 different dimensions, and so you need to think carefully about which dimension you're actually talking about, or if it's gender altogether. You know, it's not actually sex, it's just how people treat that person because of their gender, not because of what's in their body. So yeah, there are some good articles out there about the multidimensionality of sex. Anne Fausto Sterling is a great author I recommend. She's a feminist biologist who talks in depth about this. And then multidimensionality of gender. There's several good public health articles out there, including by Nancy Krieger, Kronk, Kid. You can find them if you Google multidimensionality of gender and sort of think through what's expression, what's roles, what's expectations, what's biology, what's identity. Yeah, it's complicated and fun for a nerd like me.
Yeah, and I worry about these issues as we get into more and more use of AI in medical settings and healthcare provision. AI being based on algorithms that tend to be inherently biased, especially when you're talking about, binaries only.
Like even Google like alt text for people who are sight impaired. We absolutely need alt text for people who are sight impaired, but Google will often just guess the gender of a person and say, this is a boy or this is a girl, which is incredibly dysphoric for non-binary people or inaccurate often. So stuff like that we just never thought about that we have to think about now.
Yeah. Last question from Danette. Donors and colleagues, so this is going back to the aspect of things being too sensitive. Donors and colleagues often use the language of it's too or very sensitive when queer or trans folks are advocating for more LGBTQ plus inclusion in the workplace and programming. And this language feels guttering and disempowering, especially as a queer non-binary person who's gotten to the place where Danette cultivates an experience so much joy around identities and community. Danette says it makes me feel like something that brings so much pride and joy should not be discussed and remain hidden to keep others comfortable rather than promote a welcome and inclusive space. So the question is, well, have you encountered this? If so, how do you respond? How do you recommend responding to the it's too sensitive, very sensitive argument again? If you had more to say on that.
Yeah, I think we need to ask, uncomfortable for who? I think you hit on it, Danette. It's uncomfortable for people who have not spent time interrogating gender in themselves. And a lot of cisgender people do find it uncomfortable that we exist and that we want to be seen and visible and talked about. But that is their discomfort, and that is coming from societal expectations that I really encourage them to explore. I think everybody would do well to explore their gender and gender identity. And if it comes back to I explored and I'm cis, that's great. That's great. Like you explored it. You'll be more sensitive now. You might be more feminist now. There's no harm in questioning it, and it's a privilege to have never had to question it. And like I don't think all of us should be erased because you're feeling a little uncomfortable. Like you need to go home and interrogate that internally and read some resources. And there's something about society, I don't know really why, that makes people so uncomfortable when talking about sex and gender and sexuality. And I think we need to get over it. That's easy for me to say, who's worked in sexual reproductive health for 20 years plus, but everyone should spend some time interrogating that in themselves.
I love it. Thank you. Well, we've reached the end of our session today. Thank you to everyone for participating. The chat was very active, and I did see there was a request for resources. So, Will, I don't know if you have a ready-made list that you can share with us, and we can, just disseminate that to this registration list. But thank you so much for your time and wisdom. It was great having you. I've been watching your career over the past several years, and it's been wonderful to see all that you've been up to. For everyone else, please sign up for our newsletter, the Gender Equity Unit's newsletter, and follow us on social media to hear more about upcoming webinars. We do have one coming up on March 11th with Dr. Shireen Haydari, who is the founding president of Gendro, a Geneva-based association with the mission to advance gender-sensitive research. And thank you. Please fill out that little questionnaire that was put in the chat, and please join us again. Will, thank you so much.
Thank you.